Hello, I'm Jeunesse Gaston-Gay VP at Clarius. Thanks for joining us for today's live webinar, Practical Small Animal Ultrasound, 4 cases where POCUS enhanced gastrointestinal disease management. Backed by popular demand, Dr. Camilla Edwards will be joining us in a moment. In this webinar, Dr. Edwards will demonstrate her systematic hands-on scanning techniques for the detection, diagnosis, and management of GI diseases, as she explores 4 feline and canine cases of gastrointestinal masses and disease. Using wireless ultrasound, we'll learn to differentiate between neoplastic and inflammatory diseases, and to narrow the differential in real time to support the appropriate next steps in patient management. I'd like to first welcome you to the session. You're among peers who've joined us from across the world. A big thank you to the Vet Show and NAVC for inviting so many of you to join us. You're among 3,900 doctors of veterinary medicine who registered for today's popular event. This webinar is race approved thanks to the Vet Show, so please do stay on for the full session to qualify for 1 CE CPD credit. By participating for 50 minutes or longer, you'll receive an email from the Vet Show in the coming week to redeem your educational credit. After Dr. Camilla's presentation, Claire's clinical manager, Shelley Gunther, will be performing some live scanning on her furry friend, Mabel. At any time during this session, you can use the question and answer box, and we'll have a live Q&A session with Dr. Edwards following the presentation and live scanning. Let me now introduce you to your host. Dr. Ron Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as the chairman of our medical advisory board. Hi, Dr. Frankel.
Hi, Jeunesse. Thanks for having me here again today. And to set the stage for our case-based discussion today, we wanted to just review a bit of the literature and set the discussion and the tone. These are topics that we've covered in prior webinars, and so we really focused on some review articles. The first one really focusing in on feline abdominal ultrasound and really highlighting how ultrasound is likely the most widely used modality for imaging the GI tract in cats. And it can help in many diagnoses of GI masses, foreign bodies, and disorders of various segments of the intestines. The next review article really kind of highlighted how ultrasound can be so critically useful in differentiating inflammatory from neoplastic infiltration of the small intestine. And it's crucial to helping choose appropriate treatment strategies, both in cats and in dogs. And so ultrasound being used as the first diagnostic tool really lends itself to focusing in on the diagnostic and treatment pathways, enabling an efficient workflow around your patient care. And lastly, one topic we've also covered is how ultrasound can really not only help with the diagnosis in just imaging the organs, but can help with fine needle biopsies, FNAs, of gastrointestinal masses that provide a clinically useful sample in over 2/3 of cases, thus helping really focus in on additional treatment that's required. And before we jump into the meat of the further discussion today, we wanted to just put up this poll. We know we have practitioners from across the world at various stages of practice, and say, how frequently do you use ultrasound to assess for gastrointestinal disease in your veterinary practice? Is this something that you're new to today? Are you a regular user, monthly, weekly, or is this something that's with you always on every time you're at work? And we will go ahead and close out that poll with a simple question. Great. And we really have users from across the board yet again, so that's excellent. We'll have something to share with everyone, even from the novices to the experts, as you'll see. And we're so happy to have back Dr. Camilla Edwards to lead the discussion. Dr. Camilla is passionate about first opinion level small animal veterinary ultrasound. She travels with her dog Pippi within 50 miles of Cambridge as a peripatetic veterinary ultrasonographer. She teaches ultrasound with Celtic's SMR, Photon Surgical Systems, and FOVU, and has built a thriving Facebook community that I'm sure many of you are already a member of. And through her website, she reviews ultrasound machines with general practice small animal vets in mind. She qualified as a vet in 2006 and has worked all over East Anglia, the UK. Camilla is experienced in emergency and critical care, having gained her CERT AVP in 2018. Dr. Camilla Edwards, we're going to hand it over to you.
Thank you so much, Oren. It's great to be back here and talking again with everyone from Clarius. It's been a short while, so we're going to talk today about guiding diagnosis and management of gastrointestinal disease. And I just need to mention my conflict of interest that I receive an honorarium for this lecture. So you can visit my website, fovo.co.uk, and find out lots more about ultrasound. But let's focus on what we're going to talk about today. So first of all, we need to know what is normal in the gastrointestinal tract. So we have these different layers in the wall that we can actually see in the by using ultrasound in the gastrointestinal tract. And these vary between different parts of the gastrointestinal tract, and it's really important to understand how they vary. So this is something that ultrasound is so much better at than X-ray, for example, which many of us will use in first opinion practice. So we will be able to see the lumen and what's in the content inside the lumen. We'll be able to see it, whether it's ingesta or a mucus layer or fluid, or a foreign body even. And then we've got our mucosa layer, which is quite hypoechoic and really varies in thickness in different parts of the gastrointestinal tract. Our submucosa is hyperechoic or bright, and is generally fairly thin throughout. Our muscularis is dark or hypoechoic. So a useful thing to remember is the layers that start with M are quite dark or hypoechoic, and the layers that start with S are hyperechoic or bright. So the serosa is also bright on the edge. And we can see in a loop of intestine here, we've got a longitudinal loop here with the lumen running through the center. And we've got wall on this side and wall on this side. And we can see those layers. We've got the mucosal layer, submucosa, muscularis, and then a thin serosal layer. We've also got a transverse loop here. And these are loops of jejunum that we're spotting here. So again, those are the types of things that we'll see. We'll see longitudinal and transverse loops. And we've got some reference ranges. So reference ranges really vary quite a lot. Almost every book that you'll look up ultrasound they will have slightly different reference ranges. But this is a good sort of general average of what's out there. There's no real consensus over it. But we can see, for example, that in the dog, the stomach tends to usually be slightly thinner than the duodenum, which is often one of the thicker parts of the gastrointestinal tract. And the jejunum and ileum are very similar, and the colon is particularly thin-walled. And when we're measuring, we're including the mucosa, submucosa, and muscularis, but not including the lumen or serosa, and we're just taking one side of the wall. The other advantage that ultrasound has is that we can see movement. That's something we can't do with X-ray, CT or MRI. We can see the gut moving. So that gives us a whole load of extra information with ultrasound that we don't get otherwise. And we would expect to see the stomach and proximal duodenum contract about 4 to 5 times a minute, and the rest of the intestines maybe 1 to 3 times a minute, apart from the descending colon where we don't really see peristalsis. But ultrasound is so useful from that point of view. So let's have a look at some more normal. So we've got stomach here, and we can see the wall layering the stomach is all the different layers. These mucosa, submucosa, and muscularis are a sort of equal thickness there. Down in this video here, we've got some jejunum. There's a bit of duodenum popping in there, and we can see peristalsis moving along this piece of gut. It's really useful for that. So up here, we've got some more loops of jejunum in transverse and in longitudinal. And what we'll notice, the difference between the stomach and the small intestines is that the mucosal layer is much thicker in the duodenum and jejunum compared to the stomach. In this bottom right image, we've got colon, descending colon here. So we've got a gas artifact, gas and feces shadowing here, and we can barely see the wall. It's so thin, and that's perfectly normal for a descending colon there. So what abnormalities are we actually looking for? We're looking for changes in the wall layering. So we know what wall layering we should expect in the different parts of the gastrointestinal tract. And we also care about each individual layer, the thickness of the layer. So we might see in inflammatory bowel disease, for example, a thicker muscularis layer in the small intestine. Or we might lose wall layering, so all the layers change their echogenicity and we can't tell them apart. So that's really, really key. Those looking for those wall layers, looking for the overall thickness and the individual layers thickness also. We're also looking out for plication or corrugation. So plication is where the gut sort of concertinas together, often around a linear foreign body. It's usually an acute situation, whereas a corrugation is a bit more chronic. And we tend to see a very straight serosa with corrugation, and the rest of the layers are quite wavy, whereas with plication, all of the layers are very wavy. We're also really concerned about the lumen content. Is it normal? Is it appropriate for what we know the animal has eaten? If the animal only gets kibble, biscuits, it should be fairly consistent. If it's raw fed, then we may see tiny fragments of bone, etc. But it has to be appropriate for what we know the animal has eaten. And then looking at the motility. So we talked about expecting 4 to 5 contractions in the stomach and the proximal duodenum, and 1 to 3 contractions per minute in the rest of the intestine. So is the motility increased or decreased? And is that appropriate for the case and the medication that the animal's on? I often find when we've sedated a patient for ultrasound, we lose that sensitivity because they naturally lose that peristalsis. So we don't gain that information. So that's one reason it might be wise to just look at the motility of the gut before sedating the animal. Okay, so we're going to look through some cases and show some normal beforehand. So here I am scanning Pippi's jejunum. We can't follow from one end to another, so we're going to perform a castle pattern. So I go slide ventrally, I move slightly caudally, and then slide dorsally, and then I slide caudally again and slide ventrally, and I carry on down the abdomen, just observing lots of loops of jejunum. If I find an interesting loop or a good loop to measure, I will take that. If I feel it's representative of what's going on, to get an overall feel, or if I see an abnormality, I can take a closer look at that. So this is normal gut, normal healthy jejunum, lots of loops that we're seeing here. And we're looking out for peristalsis as well. It's always worth pausing on an area just to observe any movement in the gut. And then when we get back to the bladder, that's where we pause. So let's have a look at a case where there was a lesion in the jejunum. So this was a 14-year-old female neutered domestic short-haired cat with a history of weight loss. So here we can see this gut. Here we've got the bright lumen popping in. So we've got lumen over here, but we can see the wall around it looks abnormal. So when we see some normal loops over here, we can see wall layering where we have a thicker mucosa, but then a thin submucosa and muscularis layer. But on this section here, we've got a really thick and hypoechoic section around this lumen here. So let's just take a measurement of that. You know, we're expecting around in a cat, you know, around the 0.3 centimeters, but in this case it was measuring 0.97 centimeters, so extremely thick. We can't distinguish any wall layers within this, and it's very hypoechoic, so very abnormal just on this focal section here.
And Camilla, you're doing a survey scan, right? Like you were showing, and sort of looking for abnormalities that jump out at you. That some things are sort of not standard. Because
we can't follow the intestine from one end to the other because it's so jumbled in the abdomen. So we have to sort of minimize the risk of missing any pathology. We take a systematic view of the abdomen, and we ensure we've got enough depth on our ultrasound image so that we can spot any pathology. But once we see some pathology like this, then we can just concentrate a bit more on that, optimize our image around that, fan through it in two planes. And particularly important with the gut is trying to see whether we can follow it to normal gut in either direction. So here we can see the lumen, and that joins to a bit more normal looking gut over here, and we've got this large mass around this section. And again, we've got this lumen in here, and we're measuring, and this measurement's coming out even bigger, so at 1.3 centimeters. And so talking about following to some normal gut, so I was looking at descending colon here, but trying to follow, or some jejunum, sorry, follow it to some normal gut, and we can follow through this mass to normal gut at both ends, which is an interesting thing to do, but also gives us an idea of how long this is, because it can be very difficult to get all the dimensions through the mass. Okay, so focal masses in the small intestine in cats can be due to neoplasia, or they can be due to inflammatory bowel disease. We felt that was less likely in this case. It was very, very large. So lymphosarcoma is the most common in cats, followed by mast cell tumours and adenocarcinomas. Really, to get the definitive diagnosis, we need some cells. So a mass that large, we can certainly take a fine needle aspirate from, and that's often very useful. It won't give a definitive diagnosis 100% of the time, but it's not very invasive and often yields good results. So it's a useful thing to attempt to do. Okay, so in this next case, we're going to look at descending colon, and here I'm looking at Pippi's normal descending colon. So we've gone dorsal to the bladder, and then we can see this feces and gas-filled structure here, and we've got a very thin colon wall here. I'm just following that cranially. So the descending colon is very straight, and on the left-hand side of the body, very dorsal, and we can follow it all the way to the transverse colon, quite cranial in the abdomen. You can see I've reached the spleen here, and this is the descending colon, and it sort of dives off here down towards the transverse colon. So in this case, we had a 12-year-old male-neutered Australian Shepherd dog with a history of chronic large intestinal diarrhea. So here we've got the descending colon again. It's gas filled, and we're at that point where we can see the spleen also. So it's off down towards the descending colon. And I hope you can see the difference there in the thickness of the wall compared to Pippi's normal descending colon and transverse colon. It's really very much thicker, that descending colon there. And we can see it actually on both sides. When the gas sort of clears slightly, we can see thick and walled here and thick and walled here. And we can't see any wall layering within it either. It's all hypoechoic, and no distinct wall layers there. So there we can take a measurement. This is measuring at 0.67 centimeters. And remember, the colon should be about 0.15 centimeters if we're going to measure it. So significantly thickened there. So again, we can see the lumen here and this thick hypoechoic wall with a loss of wall layering around it. And we can also see some reactive tissue around the colon here. It's quite hyperechoic and appears sort of thickened, and that's often we get sort of inflammatory fat around lesions within the abdomen, and it can often highlight changes within the abdomen for us. So here we're more at the ascending colon, where it's much more tortuous. We can see lumen through here and this thick wall around it. It's looking pretty unhappy and angry, that colon wall. But it's diffuse throughout the entire colon. So we have the bright lumen in the center and this thick hypoechoic wall around with a loss of wall layering. And again, the tortuous ascending colon with its very thick wall.
Is the distortion of the architecture also a frequent finding, as well as the thickening of the wall?
Yeah, so that particularly with neoplasia, we see that loss of wall layering in the wall. We can see it with inflammatory conditions. There's sort of overlap between a lot of the conditions, so it's really hard to definitively say just from an ultrasound image whether it's neoplastic or inflammatory. So it is important to get that fine needle aspirate or biopsy to get that definitive diagnosis. But it's really common that with a lesion we'll lose the wall layering, and that can be a very prominent thing that we spot. So with this, we saw the colon wall was thick and had a loss of wall layering in the ascending colon, but also in the descending colon and transverse colon. And we also noticed that area around the colon was quite reactive and hyperechoic as well. Okay, so in this next case, we're looking at Pippi's stomach. So we're looking just caudal to the ribs on the right-hand side, left-hand side of her body, sorry, and we can see the content, which is mostly gas. We can reduce that, the amount of gas in the stomach by fasting the animal beforehand. But certainly when we're zoomed in a little bit, we can see that wall layering quite clearly on her. And we can see that the mucosa, submucosa, and muscularis layers are all equal in thickness. So we can fan up under the ribs and then all the way down towards the pylorus before rotating and repeating that in a second plane. And then we've seen as much of the stomach as we can. We're always going to struggle in a stomach that's got this much gas in it to see the opposite wall, but we can get a good view of the wall that's nearest the probe. So in this case, we had a 12-year-old Turkish van cat who had a history of vomiting and which had improved on with steroids. So here we've got the stomach. So with cats, we often see rugal folds in the stomach. That can be quite normal. This stomach doesn't have very much gas in, but it does have a little bit of fluid. There's a little bit of gas there. And we've got some area up here which looks pretty normal with the wall layering. And we see the occasional rugal fold up here as well. But this end here, the wall looks very, very thick in comparison. It also doesn't have clear layers to it. And also we've got that hyperechoic reaction around it. And also we're spotting lymph nodes in this area. And these lymph nodes are not commonly spotted in this area. I mean, if we've got an excellent ultrasound machine, we might spot them, but they're not ones that we usually see. So these are very prominent lymph nodes in this area, suggesting again that something abnormal is happening here. Okay, so a still image of this really thick wall. So what we've got here is we've got lumen in here, we've got fluid-filled lumen here, and then we've got stomach wall all around. And this is the thickness of the stomach wall, and it's all hypoechoic, no distinguishable wall layers there whatsoever. So fanning through the stomach, as I said, there are some points where it looks quite normal with rugal folds, and then we go through that hypoechoic thickened area, and we see those lymph nodes as well popping into view. So these are the lymph nodes, these hypoechoic areas, and it can be really important to know what lymph nodes might drain a particular area, so that if we're seeing pathology, we can link them to those lymph nodes in the gut. Okay, again, so this thickened wall, we've got these rugal folds, which we really commonly see with cats, often see those, and then we've got reactive tissue around the stomach, also suggesting that there's an abnormality there. So focal masses in the stomach of cats can be due to neoplasia, it can be due to inflammatory bowel disease, and when we see enlarged, rounded and hypoechoic lymph nodes like we did, again, it can be indicative of inflammatory or neoplastic infiltration. And the larger the lymph node, the more likely neoplasia is. But these were sort of middle of the range, so it was difficult to pinpoint just from ultrasound. It wasn't possible to get a sample of the lymph node. We'd have needed to put a needle through the stomach to get to those lymph nodes. Trying from lots of different angles, it just wasn't possible. But we did manage to get a sample from the stomach wall. Unfortunately, it was a low cellular sample, and we weren't really able to get a definitive diagnosis. But as I said before, it is very safe procedure. It is not very invasive, so it is often worth trying to take a fine needle aspirate, because we will often get very useful results, and that can really shape our treatment plan moving forward. But in this case, we would need a biopsy for a definitive diagnosis. So here we're looking at how we do a fine needle aspirate. So importantly, we need to know the distance that we're going to put the needle through to get to the lesion. So here you can see me putting the needle on the side of the probe, which has got the light on, which corresponds to this marker here. So you can see my needle passing through this phantom to reach the lesion. So once I'm into the lesion, I don't want to be right on the edge. I want to be a good depth into it. I just move the syringe and needle a little bit backwards and forwards. I've already got a bit of air in there, and then I watch as I am withdrawing the needle. And then what I would do is have a couple of slides. I would gently squirt the sample onto one of the slides and make a squash preparation to have a look at those cells. So let's have a look at a case where we did manage to get a really good diagnostic sample. So this was a 9-year-old male neutered Staffordshire bull terrier who had a dramatic weight loss and diarrhea. So here we can see this very, very abnormal mass in the intestine. We can follow it down to some normal loops of intestine, and we can follow it also in the opposite direction. So really, really useful. There it becomes sort of more normal wall layering. We've got a heterogeneous mass. It's always useful to describe these things, thinking about their size, their shape and their position. Are they in their normal place in the abdomen? Their shape, is that distorted, and the size, taking measurements and thinking about the different wall layers, are they correct? In this case, obviously the wall layering is completely gone in this section, in this focal area. Also thinking about echogenicity, so we think about those different wall layers, the mucosa and the muscularis layers being dark or hypoechoic, and the submucosa and serosa being hyperechoic or bright. But this doesn't have the wall layering. We can still describe its echogenicity and its echotexture. I'd describe this as quite mixed echogenicity. There's areas that are hyperechoic and areas that are hypoechoic. And we can clearly see this lumen going through this section here. Okay, so here's our lumen, and we can follow that to some normal intestine, and we can follow it down also to some normal intestine here. So quite clearly a large focal mass, mixed echogenicity, and quite notable in size also. So if we're going to take a fine needle aspirate, it's quite well worth knowing how vascular the structure is that we're going to stick a needle in. If there is a large vessel within it, we want to avoid that large vessel. So it's worth putting colour flow mapping on to assess the vascularity. So this structure wasn't particularly vascular. I would say that before I take a fine needle aspirate here, I would certainly want to get an angle where I don't have a loop of intestine in that top left corner. We want to avoid hitting any other structures as much as possible. So we want to really avoid anything, whether that's spleen or liver, or particularly another loop of intestine, because that is fraught with potential risk. So this is more the sort of angle that you want to get, where you've got your mass over to the side and you can take a measurement. So we're going to be sticking the needle in from this corner into the mass. And we really want to make sure that we know what needle length we need, and we know how far in that is going to go. So we sort of have an idea of how much needle will be outside the body and inside the body. So because we really want to avoid hitting that lumen, that's our key thing. But there's plenty of room here to get a really good fine needle aspirate sample. So that's what we want to do. Okay. So in this case, we did take a fine needle aspirate. So usually I'd take about 5 or 6 samples. The more samples you have, the more likely you will get a diagnosis. And we could relatively easily get this mass into a safe position to take a sample from. So there was no problem with taking 5 or 6 samples. We're monitoring each time for any bleeding or any free fluid developing in that area. And if there isn't, then we can continue to take samples, and we've got the best chance of getting a definitive diagnosis, which we got in this case. Okay, so what are the take-home messages today? So I think it's key to take a systematic exam, so of each of those organs we talked about. So we talked about the stomach, so fanning through that in 2 planes, getting a good view of that stomach wall, where we expect the mucosa, submucosa, and muscularis layers to be equal in thickness. Looking at the jejunum, so we can't follow that from one end to the other, but the way we perform a systematic exam of that is to perform a castle pattern, much like we would do on a microscope slide, where we moved ventral, caudal, dorsal, caudal, ventral, caudal, until we get to the bladder. So we start in that cranial dorsal corner, and we're really observing all the loops of jejunum that we come across, and pausing to watch any peristalsis that we see also. And we looked at the colon also. So the descending colon we can follow on the left-hand side. It's really nice and straight, just dorsal to the bladder. And we can follow that cranially to the transverse colon. And then on the right-hand side, we can see the ascending colon. And then the important thing is also when we see lesions, we see focal masses, taking a fine needle aspirate is a really, really useful thing, relatively very safe and relatively non-invasive compared to doing a biopsy where we need to do a general anaesthetic and a full-on abdominal surgery to get that sample. It can be a really good starting point and can actually really guide treatment and get to that diagnosis. So characterizing your lesions as well, thinking about the size, so really focusing on taking those measurements, the shape of the lesion, how it affects the margins, so your the edge of your gut, if you like, the wall, how that's affecting the wall layering, and the thickness of the wall itself. Characterizing the echogenicity, is it hypoechoic, is it hyperechoic, and the echotexture, is it mixed echogenicity, is it homogeneous? Really describing those lesions can help you think about what the next steps you might need to do are. Also having a look at that vascularity, not only for fine needle aspirates, but it does give you more information if a lesion is very vascular, that may be useful to know generally. And take those measurements from the lumen to the edge of the gut wall, and use those reference ranges to distinguish whether they're normal or not. Sometimes changes can be quite subtle, particularly in inflammatory conditions. There can just be a mild thickening. So take those measurements, especially if it's diffuse throughout the gut. Take those measurements, that can really help. And then finally, use ultrasound guided sampling. It's relatively safe, and we see really useful outcomes, particularly with gastrointestinal tract sampling. It's as long as there's enough thickness to it and you don't feel you're at risk, you've got enough control that you can avoid hitting the lumen, then it's relatively safe and very, very useful. We often see good diagnostic samples from this. So thank you for listening. I've got a few courses coming up soon. We've just started scanning the emergency patient on Monday. Next Monday, there's still space if you want to join the basics. And the following Monday, we start the trickier bits. And then in November, the basic echocardiography course. We've got, they are 4 weeks each. And they're online and pre-recorded, so you can be anywhere in the world. I'm in the UK, but I know the rest of the Clarius team, they're in Canada. Yeah, you can be anywhere in the world and join that. And as a thank you for watching this evening, I have got a free ebook gift for you. If you pop over to fovu.co.uk/Clarius, you will be sent the ebook. You will also be sent my independent Clarius review, and as a bonus, I'm going to give you 10% discount off a FOVU course of your choice. Thank you very much for listening.
Awesome. Thanks so much, Dr. Edwards, for that great presentation. As always, I see the Q&A is filling up with lots of great questions, and we'll have plenty of time to get to those before the top of the hour. But next, we are going to hand it over to Shelley Gunther, our clinical marketing manager, for a quick demo.
Great. So I'm just going to switch cameras over. So right off the bat here, I've picked the C7 vet scanner. And I'm just using the abdominal preset. And we have a squirrel in our yard, so Mabel doesn't want to lie still. So I'm going to be using the voice controls here to adjust my image as we go here, just so that I can keep one hand on her and the other on my scanner. So very, very helpful. Sorry, Mabel.
It's nice. It's another bonus of the voice controls.
Yeah,
It
exactly.
can be hands-free.
Maybe I'll just try and scan her standing up.
Scan in the position of comfort, right?
Exactly. All right, good. Okay, so right off the bat, I'm going to start by looking for the descending colon. And as Dr. Edwards had indicated, if I can kind of look for the bladder, I'm just going to put a little bit more gel on here.
Yeah, look for the bladder. We've got the descending colon through the bladder there.
Good. So I'm in a long axis plane right now, and I can just decrease depth. Great. All right. And so I believe this is the colon, right?
It's exactly right. So you've got a nice view of it through the acoustic window of the bladder. So
great, good. And then if I rotate into a short axis plane, it looks a little bit different, but again, a very bright with a shadow behind it.
Yeah. That's quite a common view where we might mistake that for a urolith, actually, if we
too
much pressure.
It's so bright.
Yeah.
Now I should be able to follow this up. See if I can here.
Yeah, so if you slide up the side of the left-hand side of the body, you can get up to the descending colon. And you can get up above the bladder, dorsal to the bladder. There you go. It's just popping into view.
All right.
Okay. So there
just
descending colon.
Just pivoting a little bit here. So I believe this is it here that I'm seeing.
Absolutely. Yeah.
Okay.
So, nice thin wall.
Very thin. Yes. Like hard to even, I'm just going to just zoom this a little bit here. And it's hard to even kind of distinguish. But we can see some layering here.
And that's pretty normal. So on a normal scan, I won't necessarily measure the colon wall. I'll observe that it's thin and uniform, and I'll leave it at that. So there we've got really nice longitudinal view there. You can see how probe it is as well.
Yeah. So this is the wall here.
Yeah.
Excellent. It's just great.
But we can see the detail. We can see the wall layers there. We can see the mucosa, submucosa muscularis. It's impressive stuff.
Yeah, it is. Yeah. Excellent. Good. Now I'm just gonna unzoom that, and let's I'm gonna see if I can find the stomach here.
We're talking less than 2 millimeters that we're looking at.
Exactly. There. Yeah. I'll just put
it's kind of amazing that you can see it at all.
I agree. Okay.
We've got spleen and stomach, and you can see the stomach wall again. You've got a nice mucosa, submucosa muscularis layers there, which are really nice, equal in thickness.
This is it here then.
So it's a bit thicker than the colon wall, but that's nice.
All right. Good. Excellent. All right. So that's, I've just kind of, pointed the scanner up towards her head, just kind of underneath the xiphisternum. I'm sorry you can't see that with her standing up, but trust me, that's where I'm at. Great.
Yeah, great. Okay. And really highlighting that you can scan in any position, right? We talk about that in a lot of the webinars, that wherever the patient's comfortable.
Wherever they're comfortable. Yeah. I'll just get a few more seconds here.
Very important point of care ultrasound that they're comfortable because they've often got something serious going on. So
okay, decrease gain. And I'm just wondering, is this the jejunum that I'm seeing here? I'm kind of more over to her left side here.
Yeah, so that's
there we go.
So most of the abdomen, you'll find jejunum. There's lots of loops. We can see a curved loop there. We can see a longitudinal loop. We can see some
Here.
transverse loops. So yeah.
So yeah, so there we would
lots
do
of
that castle pattern and just kind of
Yeah.
go back and forth and look
Yeah.
around. Oh, there's a nice picture there.
Yeah. And just
Great.
we can also pause and watch some peristalsis possibly. She had some food today.
She has. It's been a while. Oh, there we go. There we go. Yeah.
Probably much longer than
there we go.
lovely bit of peristalsis.
Excellent. All right. Good. I'm just going to let this dog go and see if she can go and find her squirrel buddy.
Great. Thanks so much. I see the Q&A is really blowing up, so I want to make sure we have time to get over there. Please continue to fill it out and we will get to those questions. I'm going to hand it over to Janez.
Thanks, Dr. Frankel. A friendly reminder to please stay on for 50 minutes to qualify for 1 CE CPD credit, which will be sent to you by email from the Vet Show in the coming days. Before we begin our live Q&A, we have a question for you. This poll is an opportunity to learn more about our popular Claris wireless ultrasound scanners for your veterinary practice. Please complete this poll and let us know if we can provide further information, and do click on as many options as apply. Claris is available in over 90 countries. Pricing and availability does vary by region, so feel free to request a quote and pricing. You may opt to speak to one of our experts about the advantages of wireless ultrasound for your practice. If you'd like to discuss scanner features, you can select that option. You can book a virtual one-on-one demo with our experts to see the new Claris HD3 in action in a very interactive session. And we can send you more video tutorials for veterinary medicine. We've got over 400 videos in our Claris classroom, and we'll be happy to point you to the veterinary medicine videos. So go ahead and select that option if you'd like to watch additional tutorials. While you complete the poll, I'll take a minute to tell you about our Claris Vet HD3 scanners for the highest definition wireless ultrasound imaging to speed diagnosis and for safe procedural guidance for small, medium, and large animals. Our C7 HD3 microconvex vet scanner, which you saw in action today, is specifically designed for clear clinical imaging for small and medium animals like cats and dogs. We also have the C3 convex vet for large animals like sheep and horses, and the L7 linear for superior animal MSK imaging, often used in equine applications. Our third generation family of vet scanners are unrivaled for high resolution imaging in handheld ultrasound with dedicated animal presets. Claris shows you the fine details you need to investigate an area of concern, perform a fast exam, and make a confident diagnosis on your patient's first visit to expedite the right treatment plan. Each scanner is designed with not 1 or 2, but 8 beamformers and 192 piezoelectric crystals that deliver the image quality and speed only found in traditional systems, but at a fraction of the cost, representing 85% savings. Artificial intelligence replaces complex knobs and buttons to optimize imaging and streamline workflows, making our scanners fast and easy to learn and use. Claris is also wireless with zero footprint for ultimate portability to scan animals where they are, from the vet clinic to their homes. You get free movement with no wires getting in the way or startling the animals, also making it so much faster to clean and disinfect. Only Claris delivers wireless scanners with an ecosystem that includes a free app for your iOS and Android devices with free updates. Available with our membership, Claris Cloud is available to save and manage unlimited exams and create reports anywhere. Your membership also includes in-app Claris classroom videos with experts like Dr. Edwards, as well as onboarding with a Claris clinician to build your ultrasound scanning skills. And Claris Live delivers one-click telemedicine if you'd like to share live scanning with a colleague or for a second opinion. With your membership, you get exclusive access to AI-powered features like voice controls, which you saw in action today. And you get our popular advanced veterinary package that offers more flexibility with additional tools and advanced workflows for various animal examinations, for example, with finely tuned presets categorized by anatomy, more comprehensive measurements, needle enhance for procedure guidance, and the new OB growth tables for both dogs and cats to obtain accurate estimation of gestational age and fetal growth. With increased ultrasound billings, you'll see a rapid return on your Claris HD3 vet scanner, which is ultra affordable. We'll now close off the poll in 3, 2, 1. Thank you. If you ask for more information, we'll get back to you in the coming week. Our last poll is actually an invitation to pre-register so that you can join us for our next webinar with Dr. Camilla Edwards. It's entitled Guiding Diagnosis and Management of Urinary Tract Diseases. Please complete this poll to save your seat for our November 7th webinar, and we'll send you a confirmation email in the coming days. We'll give you a few moments to save your seat. And while you do that, we will begin our live Q&A session. Please use the Q&A icon in the menu bar to ask your questions for Dr. Edwards. And because it's a common question, I do want to let everyone know that in the coming days, we'll send you an email with a recording for today's webinar. And if you stayed on for at least 50 minutes, you'll receive an email with a link from the Vet Show to redeem your CECPD credit. I'd like to welcome back Dr. Frankel to moderate our Q&A session.
All right, here we go. Camilla, there's a lot of questions. People have a lot of questions about FNAs. We've discussed this in prior webinars. Maybe we can give a quick refresher on, do you worry about seeding with an FNA? And what about other risks like fecal contamination?
Yeah, so sampling the gastrointestinal tract is not the first thing to try doing fine needle aspirates on, because absolutely hitting the lumen, it can be catastrophic. If we do puncture the lumen and we cause a peritonitis, that's a much worse scenario than we started with. So we absolutely don't want to do that. So we need to be really confident at our skills with fine needle aspirates. So I wouldn't suggest the gut as the first thing that you try that with. Getting good at cystocentesis, and where you're really confident you can see the needle the whole time entering the bladder and getting that sample and then withdrawing the needle. Once you're really confident at that, trying really superficial organs like the spleen are the next things to try. And once you're really confident you know where that needle is heading when you're putting the needle into the animal, and you're sure about the thickness of the gastrointestinal wall, and you are sure you're not going to hit that lumen because you understand three-dimensionally what's going on around that, before being fully confident about that, I wouldn't approach fine needle aspirate of the gut. So yes, there is that risk of puncturing the gut, but that's why you need to watch the needle the whole way through, and you need to stop if you can't see the needle. So that's so important, especially when it comes to the gastrointestinal tract. Yeah, what was the other thing you said, Oren?
No, I think that was it about, particularly, well, and seeding. The question comes up about seeding. Yes.
So seeding is theoretically possible. It's where we might be sampling a neoplasia, and we draw some of those cells up into the abdominal muscle wall and leave them there, and they develop into a tumor in the abdominal muscle wall. And this has been described with transitional cell carcinomas in the bladder, but we're really talking about cases that are discussed. It's not a case of when you do 100 of these, 3 of them will seed. There are case descriptions of this in the literature. So it's pretty rare, and it's something we need to be aware of, but it's not a common thing. And we have to weigh up the pros of fine needle aspirates being a very exceedingly good tool to get to a definitive diagnosis with minimal risk, compared to a very, very tiny risk of seeding. And you absolutely have to discuss that with the client. But if the alternative is doing a biopsy, that has its own risks as well. So we really have to juggle or weigh up these risks, and know before we've taken the sample, we don't know what it is, and we don't fully know the risk of this particular mass seeding. So it wouldn't put me off taking a fine needle aspirate in the gastrointestinal tract.
Okay, great. There's with a lot of these questions, I think I might refer for a lot of the FNA questions to your other webinar on FNA, where a lot of this is described in detail. Maybe you can just kind of quickly brief, maybe suggestions on people who are either just getting into this or how they can refine their FNA technique.
Yeah, so definitely start by getting good at cystocentesis. So we want to be able to see the needle the whole way through. So we're not going from the side of the probe. I've often seen people trying to get a sample where they're putting the needle and they only see a tiny section where the needle is. We really want to have the whole needle in the whole plane of the ultrasound image. Making sure that you don't have any gel on the animal, because any cells might explode. Pathologists really don't like when you use gel, so using spirit instead or alcohol instead. Not only is that nice and sterile, then it also is a very good coupling agent to enhance your images. Making sure the needle is very close to the probe, but not so close that it's touching the probe. And we certainly don't want the needle to be passing through the rubber on the end of the probe, because then we'll damage the probe. So very, very close to the footprint of the probe, inserting the needle, making sure we know what needle length we need, so we're not puncturing and then realizing that we need a longer needle. And particularly with cystocentesis, often the problem when we're not getting a sample is because we haven't got a long enough needle. We need to measure so we're well within the bladder, and so that when we draw back on that syringe, we're not just drawing back on a bit of wall and sucking wall into the needle. We're actually punctured into the bladder and getting a sample in there. But really getting very good at cystocentesis and very confident that we can see the needle the whole way before we start trying to do other organs. Also using phantoms like the one I was using. You can certainly buy phantoms like that. You can also make phantoms. We discussed that in the fine needle aspirate webinar. You can make them yourself, tofu or a bit of meat, and inserting an olive into that. That's a good thing to practice on as well. But once you get good at those, doing superficial organs like the spleen is a good thing to do next.
Great. And we're approaching the top of the hour. I'm going to squeeze in, there's a bunch of questions here. I'm going to try and consolidate. Maybe you can talk a little bit about the findings around foreign body ingestion and how they might mimic either chronic inflammation or even malignancy, and how to tell between those, if you can jump on that.
Foreign bodies are difficult. There's a reason we're all focused on foreign bodies, because they're really difficult, because there's a whole variety of things it could be. Foreign body is not one thing. So they will show up slightly differently, but often because they're quite different to soft tissue, then you'll get a hyperechoic area and you'll get an acoustic shadow. It will often be unusually round or unusually straight if it's a man-made object. And yes, you can, with linear foreign bodies, you can certainly get a plication or a concertinaing of the gut around the linear foreign body. Another thing to watch out for is if it's causing an obstruction, you may get a dilation of the gut orally to the obstruction. And yes, you may get hyperperistalsis going on as the gut tries to move that along. So those type of things, but it can, if you've only got partial obstruction, it can be very, very difficult to spot. It's not an easy thing.
I'm going to sneak one last question in because it was repeated a lot. Where can people learn to identify more pathology and understand what it looks like and kind of put it in their mental library, I guess?
Okay, so Well, over at FOVU, we've got lots of free content with newsletters. If you sign up to that, to get that ebook at fovu.co.uk/Clarius, we will send you weekly free cases and that sort of thing. Also on the Clarius website, I've shared lots of cases on there as well. So in the education section, there's lots of pathology to see in that section.
Great. Well, thanks so much. I want to respect everyone's time, and we're above the top of the hour. We will be following up with any unanswered questions that we weren't able to get to today. And Janez, I'll let you take us home.
Yes, and just a friendly reminder that you'll receive a copy of the webinar recording by email in the coming week, and a link to a PDF of the presentation as well. We do please encourage you to take our closing survey to give us feedback so that we can continue to bring you great educational content like today. I'd like to conclude by thanking Dr. Edwards and also thanking Dr. Frankel, Shelley, and all of our furry supporting characters. And of course, a big thank you to you for joining us today. We hope to see you again on November 7th for our next webinar with Dr. Edwards. And in the meantime, keep scanning. Thanks and bye-bye.